Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome into the new episodes of our case histories discussion on gut-brain axis. Till now, we have discussed 3 case histories: the IBS patient, then the case history of the functional dyspepsia patient, and then the case history of post-infectious IBS patient. In today's vlog, we shall discuss the case history number 4, that is the functional constipation patient. Case history number 4, the functional constipation patient, brain-gut motility dysfunction. It's a case history of 55-year-old female with a history of anxiety and presents with chronic constipation. She has hard stools, straining with incomplete evacuation. Colonoscopy was done and that was normal. No red flags, but lifestyle changes and fiber have not helped. According to No-4 criteria, she is qualifying for functional constipation. So 55-year-old female with history of anxiety with functional constipation according to No-4 criteria, and she has chronic constipation and she complains of passing hard stools, straining at defecation, and there's incomplete evacuation. And her colonoscopy was done, that was normal. There are no red flags. The lifestyle changes were tried and fibers was tried, and this did not help. So what's driving her symptoms? This is the question. Then she's got no functional, no pathological mechanisms or reasons for her constipation. And she has tried lifestyle changes. She has tried fibers. Colonoscopy is normal. No red signs, but still she is symptomatic. So what's driving her symptoms? So the possibilities is, or the reason is gut-brain dysregulation and dyssynergic defecation. This is number 1. And then overlap with IBS constipation predominant. So let's understand what do we mean by the gut-brain dysregulation or dyssynergic defecation. First, we discuss this one. There's a neurogenic control of defecation is altered. In such patients, the neurogenic control of defecation, we know the sphincters and their neurogenic control, it is altered. That is, there's inadequate rectal contraction, rectal muscles contraction, and paradoxical anal sphincter tightening. So there's incoordination, there's the anorectal dyskinesia or incoordination, and this leads to the functional constipation. Then there's overlap with the constipation predominant IBS. The functional constipation lacks significant pain, whereas IBS-C includes pain and bloating. So this is the difference between these two mainly. So what should be the management approach for such patient? Dietary modification, this is important. Of course, pharmacological interventions are also important, and equally important is the pelvic floor retraining. You retrain the pelvic floor muscles, and of course the mind-gut therapy. So let's understand the dietary modifications, how it helps, how it should be. Of course, to increase the fiber, this is the baseline to increase the fiber in your diet. And of course, plenty of fluid. These are the basics. And you should not forget this. Even in functional constipation, the dietary modification includes these. Then in the pharmacological interventions, the targeting the brain-gut axis is the important. The low-dose tricyclic antidepressants or SSRIs They modulate serotonin-driven mortality, and they should be tried. Then the procalopride or lubiprostone for prokinetic support of the sphincters and the muscles is very, very important. And then the pelvic floor retraining. This is again a very important component. Biofeedback therapy. Biofeedback therapy, that's a gold standard for dyssynergic defecation, and it should be tried. Then there's abdominal massage techniques. You can find these on the YouTubes, you can find these on the other platforms, so these should be tried. Then the mind-gut therapy. The gut-directed hypnotherapy has been shown to improve the mortality in chronic constipation, and it should be tried. So the key message from this case history number 4 on the functional constipation patient is that not all constipation is a fiber issue. Brain-gut dysfunction plays a key role in functional constipation, and we should remember this. So just a review of our key takeaways from this case series. The FGIDs or the DGBIs are real, not psychosomatic. The gut-brain axis dysfunction leads to visceral hypersensitivity, dysmotility, and dysbiosis. The diagnosis is clinical, round 4 criteria, so avoid unnecessary tests unless red flags are present. And the multimodal treatment works best. Dietary therapy and psychological interventions and targeted pharmacology, these are the 3 components of multimodal treatment. And remember, the future lies in the microbiome-based therapies, including postbiotics, fecal implant, microbiota implants, and the gut-specific neuromodulators, including serotonergic agents targeting the ENS. So let's continue the conversation. What's your biggest challenge in managing IBS and functional dyspepsia patient? Please comment below. And with this, we come to the end of the case history number 4. I'm thankful to you for being with me during all these case histories discussions. Inshallah, in the next vlog, we shall discuss the 5th case history. Till then, take care. Khuda Hafiz.